So, for those of you who don't know, I'm Christian John Lillis. I'm the co-founder and CEO of the Peggy Lillis Foundation. I'm really glad that you're joining us tonight. Everyone at PLF is really pleased to be hosting tonight's webinar, Household Hygiene for People with C. diff. Besides treatment concerns, the most common questions we get are about cleanliness and hygiene. People battling C. diff are scared of giving it to their loved ones. They're scared of it coming back. So I'm really pleased to have a true expert with us tonight. Dr. Kathy Egan is a public health inspector who has expertise in infection prevention and control. She recently finished her PhD on the topic of household hygiene for people with C. diff, so very specific PhD on this topic. Dr. Egan also holds an MBA and has been certified in infection control since 1994. Dr. Egan is currently a professor in the Bachelor of Environmental Public Health program at Conestoga College, where she prepares students to become public health inspectors, which we all love, but are probably the bane of lots of businesses' existence. Dr. Egan has about a 35-minute presentation. There's going to be a period where she's going to ask for questions, but beyond that period, we're going to have then a Q&A period at the end, and we'll address the questions we received in advance and also provide an opportunity for the audience to ask questions. We do ask that everyone stay muted during the presentation so Dr. Egan isn't interrupted or we don't have like background noise that makes it hard for us to hear. And then once we move to Q&A, you'll be able to type your questions in the chat or come off of mute to ask them. So without further ado, please welcome Dr. Kathy Egan.
Great. Thank you very, very much. And thank you for inviting me to share my research with a group that probably has the very same specific interests that I do in this topic. So this is just my cover slide. I will move to my quick agenda. I would like to give you a little bit of a background on C. difficile, which I'm sure you actually know, but there's a few specific characteristics about C. difficile that are relevant when we think about household hygiene. Then I'll tell you about my research, what we found, and the moment you've all been waiting for, some interim household hygiene guidance advice. I will say that the reason I say interim is because myself and some other experts, actually in Canada and in England, and actually I've got a few in the States now as well, are going to work to do an official guideline. So right now, what I'm telling you are things that I think are basic knowledge, but there will be an official guideline coming out soon. So just a little bit about my background that hopefully takes what Christian said to make it make a little bit of sense. I've worked in public health for about 20 years. And during that time, I've interviewed people who've had infectious diseases, and I've worked with healthcare facilities to manage infectious disease outbreaks. So I've worked both with individuals in the community and hospitals and long-term care homes. And I've explored the challenges of trying to implement a new program or education things. So in this slide here in the big green box at the bottom, one of the things that is a big takeaway for me is that patient information and having people who are affected by an illness or an infection, having them know what to do is a really important part of successfully controlling that infection, be it C. difficile or any other one. And our healthcare system really is a system in the sense that hospitals are not distinct and totally isolated from long-term care homes or communities because people come and go from those places. And when we come and go, we take our germs with us. So the problem we're going to talk about today is Clostridioides difficile, shortened to C. difficile, as you know. So it's an anaerobic, spore-forming, toxin-producing bacillus. And the important part about this first bullet is that it's found in the intestines of humans and animals. And what that means is the infectious part of our body fluids, or how it's transmitted from one person to another, is through feces, as you probably know. But we just need to remember that as I'm going to talk about hygiene in a second. We didn't discover it until 1935, and we didn't think it was a problem. It was just a bug that they identified. Then in the 70s, they found out it actually caused illness. And then by the 1990s, we realized that it was one of the most common causes of antibiotic and healthcare associated diarrhea. And in the 2000s, there's a specific strain of C. difficile that emerged that caused really serious illness. And so that's when it really got a lot of attention from public health and infectious disease experts. So because C. difficile, the infectious part of a human experiencing C. difficile, is in their feces, that's where the spores are excreted. And then how another person gets it is by ingesting those spores. I'm deliberately using my hand for that purpose to demonstrate that because it's the fingertip transfer when we touch surfaces that are contaminated and then touch food or put our hands to our mouth that really can cause us to swallow the spore. Once you swallow the spore, you are colonized. That means you have the organism in you, but you don't have any symptoms. To get the symptoms, you have to have a disruption of the flora, the organisms in your gut, through antibiotics or through proton pump inhibitors or some other thing where your normal gut flora gets disrupted and the C. difficile is allowed to grow. And when it grows, it creates a toxin, and that's how you get the symptoms. And then you excrete the spores. Three things on this slide are very important. It's a low infectious dose, meaning you don't need to ingest a whole lot of spores to actually become sick. That is based on experiments with rodents, because it's not an experiment we would want to do with people, but we believe that it transfers to people as well, thinking that it's a low infectious dose. Another really important thing is that studies have shown that people excrete the spores in their stool for about 5 weeks after treatment. And I'll explain why I think that's really important for household hygiene in a second. The other thing about spores, you probably know this, they remain dormant in the environment for a long time, and they're not killed by heat or dryness or disinfectants, which are often the way that many germs will be destroyed in the environment. This is a graphic depiction of what I just said, thinking about how this human over here ingests the spore, and then it goes into their gut. And once the spores germinate, the toxins are produced, and you shed the spores. What is interesting on this slide is the box at the bottom that shows community, so people that might be around that infectious person, infants. Fun fact, up to 70% of infants are colonized with C. difficile. They aren't sick with it usually, but 70% of infants, and it's really not clear why that is. So that it could be a place that someone could pick up C. difficile from handling feces of infants as you would through diapering. Hospital and healthcare settings are a place where people could go and excrete their spores. We've also found it in food and water and animals and the environment. One thing about organisms that spread in your feces is they are often found in the environment because they're quite hardy. If it can live in your stomach where there's stomach acid and all kinds of unpleasant things, it's likely that it can survive in other places as well. So then another person could be exposed to the spores, and that's how it's transmitted person to person. Now, there's risk factors for C. difficile infection, or I'll call it CDI from now on. And the risk factors for a hospital-associated CDI are rather well known. The risk factors for community-associated CDI, meaning you get sick without being in the hospital, are a little bit different, but some are quite the same. And what's really important here is that we're now recognizing how much transmission happens in the community, because our previous thinking was that it was pretty much only in the hospital and that was the only place you could get it. And that is becoming much more apparent that we were wrong on that thinking. So another really important thing about C. difficile is you can have recurrence, meaning it comes back. And that can happen in two ways, a relapse or a reinfection. And a relapse means the vegetative cells, or the cells that grow, or the spores that might still be in your intestine after treatment, they reactivate for some reason. Or a reinfection, meaning you touched something in the environment and swallowed it again. So, and you can't really tell the difference between those two things because the only way to test is to test the stool and do the typing, but it still is just going to tell you if it's the same type that you had the first time, at which it would be the same for either of those instances. And recurrence is a big problem because 15 to 50% of people who have CDI have a recurrent case. And it's serious, and 34 to 50% of people who have it are hospitalized. So I see some questions coming in the chat. I'm not reading them though to try not to distract myself, but I would just like to invite you at this point, and throughout my whole talk, if you have specific questions or worries, please put them in the chat. As Christian said, we're going to collate those. If there's things I can address now, I will. And if we have to get back to you, we will do that as well. Okay, this diagram shows kind of what I've described already, but thinking about it in a healthcare environment. So you have the exposure, meaning somebody swallowed the spore, and then you become infected or colonized. So colonized means I have it, but I have no symptoms, or I get an infection. Either way, I could excrete those spores in my stool. And when I do, just because of the mechanics of having a bowel movement, your hands are potentially going to be contaminated after that. So then I might touch surfaces in my patient room, or I might touch portable equipment like a walker or other kinds of healthcare equipment. It's going to get on my skin and my bedding and my clothing, again, just through being on my hands. And then it gets on healthcare workers' hands because they're providing care for me, and then they might spread it to another susceptible patient. And we know that the environment is really important in healthcare settings because up here on the top, it says previous occupant of a hospital bed. Studies have shown that you are more likely to get C. difficile if you are admitted to a bed where the person before you had C. difficile. And that's because they might have contaminated the environment, and cleaning it is very difficult. And you probably know that, which is why you're here at this webinar. This is a picture of a hospital. Now, I'm in Canada. That's where I'm located. Our hospitals do not look like this. I don't know if yours do. This is probably like the best hospital room you could ever look at as far as how it's set up. It looks like it would be a nice place to recover, nice finishes as far as cleaning and disinfecting. They're all, nice and tight, and you can clean things effectively. Now, when you're looking at it, if we had more time, I would ask you to tell me where you think C. difficile has been found. We don't have a lot of time, so I'm going to jump to that and tell you right away. All of these red crosses are places where researchers have found C. difficile to be present. Now, this makes sense if you think about it being on your hands, right, after having bowel movements, or on the healthcare workers' hands as they're coming to give care to you. So all around the patient's bed, pillow, linen, bedside table, the chair where the patient probably goes and sits and maybe uses the hands, like the arms of the chair to push themselves to get up, the sink where you're going to go and wash your hands, and the floor. Now, the floor has been controversial in infection prevention and control for a long time. And we used to think, it's not a problem, don't really worry about it. But what happens with the floor is if you can imagine somebody coming to, fix up the bedding and fluff your pillow and put the sheets on you, there can be aerosolization of any spores that are on the linens that fall onto the floor. And you might think, well, that's no big deal. It's on the floor. But if you're in the hospital, you might be walking around with slippers on, and you might have those ones that they put the sticky thing on the bottom so that you don't fall down, which is fantastic for reducing the risk of falls, but it's bad that it might pick up spores that would be on the floor. And then you might get into bed with your slippers on, so then you've potentially dragged more spores into the bedding. So it can transmit around quite a lot. Many people are now calling this the journey of the germ, which I think is a nice way to think about it because the germs don't crawl around themselves. Our actions may tend to bring them along with us and put them in places where they shouldn't necessarily be. Now, this is the same diagram, but thinking about transmission in households. So if you're a recovering patient with CDI and you are discharged home, you're probably still excreting spores, right? Because 5 weeks after treatment, it's still in your bowel movements. So you might then transfer it to high touch surfaces in the home, just on your fingertips. If you have home care equipment like walkers or things like that, or your skin, bedding, and clothing again. And then it's transmitted to hands of people who touch those surfaces, so your household contacts potentially, or yourself if you're the CDI patient. And then colonization or infection happens again. So now this is not my bathroom. I don't know whose bathroom it is. It was just a photo I found online, but it could be a typical bathroom. And so if you think about the hospital bed I just showed you and the X's that were there, you could probably take a guess again where the red crosses might be here. So after having a bowel movement, the first place that you're going to touch is probably the flushing handle, right? So that's going to be the most contaminated because anything that might be on your hands, uh, and obviously there's toilet paper involved, but it's not, it's porous. So anything could get on your hands while the bowel movement is happening, right? So then you touch that handle. Then maybe you go over to the sink and you're going to touch the taps to turn them on. Your hands are still dirty. You wash your hands, but then maybe you touch the taps to turn it off. You've maybe recontaminated yourself. So you have to think about that. Now, over here, there's a toothbrush and a toothbrush holder. You're probably thinking, well, how could that get contaminated? In this picture, the toilet lid is closed, but many people flush with the lid up. And you can't really see this when it happens, but when you flush a toilet, there's kind of a plume that happens. And that aerosolizes anything that's in the toilet bowl. So most of your feces go with the water that's flushing out, but some of it, and C. diff spores, if they're there, and other bacteria and viruses, can be aerosolized, and then there's sort of this plume that can settle over anything that's an open surface in your bathroom. So studies have shown that toothbrushes and things like that that are left out on the counter can become contaminated when you flush the toilet. Oh, and the last one here is the doorknob to get out of the bathroom. And of course, the floor, which would be the same concern as in the patient room, except that you're probably not directly getting into bed. Your bed is going to be a little farther, but you could still pick up the spores and take them with you. Okay, so this is a timeline that kind of puts all of those things together. So if you imagine over here in week 1, you start to get sick, they take a stool sample, they diagnose you with C. difficile. And when you're in the hospital, you're on contact precautions. So anyone near you who comes to see you, they have gowns and gloves, right? Because they need to be very concerned and conscious about not picking up the spores. Then the gold line here, you're going to start excreting spores when you are symptomatic. Uh, and the bar here gets a lighter gold color because while you're on treatment, you shed less spores. Studies have shown that in quite a few studies. Then the bar gets golden, dark golden again, because this is the 5-week period after treatment where you could still be excreting spores. Then this green bar is the spores and how they survive in the environment. So you probably left some behind in the hospital. And if you see the blue bar here where you were discharged, maybe when your treatment started, uh, you are discharged home where you're excreting spores, and then the spores are in the environment where you're continually potentially being exposed to them. Then the last line here is a period for vulnerability for recolonization, meaning your system is feeling like it's not able to fight it off. Like maybe you just haven't got your normal flora back up, and you may experience that because of lactose intolerance and things like that. So your body just isn't totally back to normal, and it's more susceptible to uh, the spores that you might pick up in the environment and swallow, and therefore you may become more likely to get sick. So putting all of those time things together, for me during my PhD, this was the time where I thought, oh my goodness, it really is an issue that you're likely to be excreting spores. They're surviving in your environment. Household hygiene is really, really important. So in the hospital, the IPAC protocols they use and the cleaning and disinfection, very strict. In the home, it's a big question mark. And we all do different things in general, and we're taught by our parents or our families about how to clean the house, and that can be just varied. But we don't really have a good way to clean the house or to do household hygiene when we have C. difficile. So that was our research question. What household hygiene advice would be effective for people with C. difficile? So we did three things. We asked all the hospitals in Ontario, Canada, to tell us what information they gave out to people. And we looked at their fact sheets and we did an analysis of the content to see if we thought it was effective advice. Then we looked at the literature, like the scientific literature, to see what other people had studied about household transmission of C. diff. And then we talked to patients to see what practices they did and what their knowledge was. So about half of the hospitals we talked to said they had policies to provide household hygiene advice. Only 23% of them, though, said that they always provide that information. And 10 of 24 of the hospitals without policies said they provided information anyway. The barriers to not providing the hygiene advice was not enough time to talk to people. They didn't know what information to provide. And they said that there was lack of interest from patients to receive information, which I think that might come from the fact that all the fact sheets said there's a really low risk of this in your home, so don't worry about it. So I think people thought it's not a problem, so why would I, need information? But 65% of the infection control people in the hospitals said they also believe the household environment is a potential source of transmission of CDI. When we looked at what all the information sheets said, uh, none of them said anything that was adequate in our belief. And I worked with three other people who, one is like a well-known Canadian expert on C. difficile. We didn't think any of them really gave good advice. It downplays the risk of transmission. It describes a basic level of hygiene that is inadequate to prevent transmission. They just talked about regular and thorough cleaning, but did not give a definition of those. And I'm sure if we asked all of us here, we would all probably give a different definition. Only 39% of the fact sheets talked about a chemical agent that had bleach in it. And that's really the only thing you can get for households that's sporicidal. And only 6.5% of them talked about the specific dilution. That means how much bleach and water you put. So you can't just take like a little bit of bleach and put it in a cup full of water. That's not going to be strong enough. It has to be a very strong concentration of bleach to be effective. And 35% of the fact sheet said an all-purpose cleaner was sufficient. And most of us, I think, use an all-purpose cleaner when we're cleaning our bathroom on a regular day-to-day basis. You go to the grocery store, you pick it up, and it's Mr. Clean or whatever. But those are not sporicidal. I'm going to skip over this, but this is just if you're into science or research at all. This is showing how we did our literature search, found over 1,000 articles, but when we screened them down, we ended up only with 19. So there is not a lot of good evidence that talks about C. difficile transmission in the home. It did tell us, though, that C. difficile has been found in lots of places in your home, whether you have C. diff or not. The kitchen sink, your refrigerator, toilets, the contents of your vacuum, pet food bowls, garden, compost soil. So that might be disturbing because you might think, oh, I can never escape this. It's everywhere. It's in higher concentrations, though, in the home if there's a sick person there. And even though it was found in a lot of homes, they don't know how many people got sick from that because there's that extra step when you have C. difficile before you become sick, right? Where your gut flora has to be disrupted. It's not like influenza, where if I have it and I sneeze in my household and other people are close to me, then the chances of them getting influenza are great. And they get it within an incubation period of about 5 days. C. difficile has that extra step where you could be colonized with it, and that might be easy to transmit, but you don't know unless you test for it, or if the person's gut flora gets disrupted and they get sick. So we talked to people who had C. difficile and we did interviews with them. And we got those people through a hospital who sent out the letter for us and then invited them to contact us. We only got 7 participants, even though the letter went to 104 people. but we were happy to get 7. And I'll talk about the hesitancy there in a minute. 4 people allowed an in-person interview, meaning I went to their home and talked to them, and 3 people talked to me on the phone. So here's what we found: a lack of knowledge of how CDI is transmitted. Even though these people actually had CDI, there was still a confusion about how it transmits from person to person. This isn't typical of everyone, but the people that we talked to in general really didn't understand how they got C. diff. And for me, that's a key for you to be able to think through how you can prevent it. You have to think about how it's transmitted. And the way that C. difficile works, the pathogenesis, is complex. So I totally understand that it might be confusing for people, for non-healthcare people. In fact, I talk to a lot of healthcare people that still are confused about it too. So I understand that. One thing too is people said, well, nobody else in my house got sick, so obviously what I did was effective. But again, they may be colonized. We don't know unless we test them. We need to do more studies that would look at that. And people didn't really talk about the need for frequent, ongoing decontamination of contaminated surfaces. I purposely use that word decontamination instead of cleaning because the practices that we need to do during that 5-week period when you might be excreting spores, the decontamination is what you're going for. I'll explain more about that in a second. So as I said, the household hygiene information that was provided did not describe an effective level of household hygiene. And there are no products we can get in Ontario in our grocery stores or drugstores that would be sporicidal, except for bleach. And you have to mix it at a high concentration. So the participants we talked to talked about cleaning their homes as far as visible cleanliness. Almost everyone said, I dust and, I clean the floors, which is great. And, that's an important thing for your house to look clean. But uh, they really rarely talked about pathogens and their survival on the surfaces. The other thing we heard a lot, and you will know this if you are someone who has had C. diff, is it takes a physical and emotional toll. And discussing feces and household hygiene are very embarrassing. People used words like depression, guilt, and shame when they were describing their illness. And I think that embarrassment may have prevented people from asking questions about household hygiene, which makes people in hospitals think they're not interested. I also think this embarrassment prevented people from participating in our research because they didn't want to talk about it, and I totally understand that. Here are 3 of my favorite quotes that people said. One said, it's a taboo discussion, whether it's culture or your beliefs, you don't talk about it, about poo. Someone else said, I've thought about this quite a bit, and it's a very, very difficult subject for people to address because the way they clean their house is sacrosanct. And people don't like talking about poo. So that's 2 things that are pretty emotionally charged that people probably don't want to talk about. My favorite quote, though, was after I had just explained everything, like I just explained to you, someone said to me, well, I'll tell you, probably about 95% of the population has no idea what you just said, which kind of loops back to what I said in one of my first slides, that patient information is so important. So one of the goals of our research is to try to figure out how to get the proper information to people. And certainly 95% of the population is thinking about everybody. People who've had C. difficile probably have a better understanding than most, but it still is a confusing disease to understand. Okay, implications for practice. That means how are we taking our research and what are we going to do about it? So in the course of my research, I encountered a philosophy called targeted hygiene. And it is the idea where you think about the risk, and that tells you when and where you need to clean or provide hygiene. So if you think about if you were in the hospital and you had C. diff, and they maybe cleaned your room twice a day. So people always ask me that, probably the same questions they ask Christian. How many times a day should I clean my house? To me, it's not the frequency of the cleaning, because if you picture that slide I showed with the bathroom, and you have a bowel movement, and maybe it's, a diarrhea, which is particularly messy, and you flushed with the lid up, everything in that bathroom is contaminated. If I wait till the end of the day to clean that, but other people are using it during the day, then I don't like, we've missed the boat there, right? I think you have to clean after every bowel movement during that 5 weeks that you're potentially sick. So, or that you're potentially excreting the spores. So, the idea of targeted hygiene is thinking about the moments and where you need to actually do the cleaning. Hand hygiene is also important too, because if any of the surfaces are contaminated, but you still touch them, if you clean your hands before you eat or put your hands to your mouth, that will reduce the number of spores that might be there and therefore reduce the risk. And you should think about hygiene more when someone in your household is infected, be it C. difficile or any other thing, really, or if someone in your household is extremely vulnerable. So if someone's having cancer treatment or has immune challenges, then you're going to want to think about doing extra hygiene then. So, what we would like to do is help people understand that even if your house looks really clean, like your mirrors are shining and there's no dust, if you didn't decontaminate properly, there could still be spores there. So I really want people to understand when we're finished our guidelines that cleaning is one thing, but a hygienic clean where you're actually destroying the spores is what you need to think about. So to do that, you have to do a risk assessment or this targeted hygiene philosophy where you think to yourself, okay, I understand the routes of transmission. It's fecal oral. I know when there's feces that are being deposited, like if there's a fecal accident or soiled laundry, that should be handled really carefully because it's highly contaminated. You need to identify sources and reservoirs in your home. So the bathroom is probably going to be one of the things you think about the most. And then identify, we call it a critical control point, but that's just a fancy word for where and when I need to provide some hygiene practices. And then you need to understand the appropriate hygiene intervention to do. And that means what sort of cleaning agent and how do I handle even my cleaning cloths, my mops, that sort of thing. So this is what our plan is. We're going to develop these guidelines using evidence from the literature. So we'll do a whole bunch more literature searches to see if other people have studied how long spores live in the household environment, that kind of thing. When we develop that guideline, then we will make information in accessible formats for people with CDI. Because people like me like to read the guidelines and all the background, but I think most people who have CDI really just want to know, what do I need to do in my home to be safe? So we can chunk that out into little videos that you can watch on YouTube or quick fact sheets or stickers you can put up to remind yourself, that sort of thing. Then we want to train healthcare providers on the guidelines because as people are discharged from hospital, I want them to get good information so that they know what they need to do. And even if they can just be aware that our information exists. Okay, interim household hygiene advice. So this is me from what I've learned. This isn't yet the benefit of all of the experts that we're going to convene, but these are things I thought I can confidently say to you, I believe you should think about doing. So you should do targeted hygiene for at least 5 weeks following treatment. And that means thinking about the risks in your home, where and when spores could be present. Think about the commonly touched surfaces that could be contaminated with feces. So your bathroom, any assistive devices that you have where maybe you had to use your walker to get up from the toilet and then go clean your hands. So that's going to be contaminated. A terminal cleaning, that means a really thorough cleaning with sporicide should be done at the end of that 5 week period when your treatment, like 5 weeks after your treatment, because that should hopefully reduce the amount of spores that might be there. You should consider using that targeted hygiene approach in general, though, not necessarily cleaning after every bowel movement, but if there's times where someone in your house might be susceptible or someone might be infected with something, thinking about the journey of the germ in your home is a good thing to do. It's good to remember that feces are the infectious substance. And sometimes feces is visible and it's easy to see, and we all know to avoid it, but it sometimes is invisible. A colleague of mine once said, it's like a fecal veneer. So if you're familiar with veneer furniture, where it's a desk, but the top layer can kind of be peeled off because that's the veneer. Well, if you do tests of many surfaces around our homes or in public places, you will find there are fecal organisms on most of them. So he described it like there's a fecal veneer over everything, which for me was an important thing to think about because now I clean my hands if I've been outside or touching anything that other people have touched before I eat or touch my face. So the things that we know touch feces are the things you can think about and disinfect right after they're contaminated. Ensure the disinfectant that you're using is sporicidal. So chlorine bleach is the most readily available product, and just the regular stuff that you buy in the grocery store is usually 5% chlorine. If you take that and you take 1.5 tablespoons of bleach to 4 cups of water, that will give you 1,000 parts per million, and that's the concentration of it. And that is sporicidal. But it's not that easy. It still has to, the surface has to stay wet for 10 minutes. So if you've ever done that, like cleaned a surface with a disinfectant, you spray something, or even if you wet a cloth and touch the surface, um, it, uh, it, uh, it, it won't be effective unless you let it sit for 10 minutes. And that means you're going to have to reapply it a few times. So the time that you should disinfect a surface is right after the contamination before anyone else touches it. Like if you're really truly committed and concerned about transmission like this. That fingertip transfer is an effective way for spores to be transferred. And your personal hygiene is important. The hand hygiene I mentioned, but even something like showering instead of bathing. So if you think about, that the spores are on your hands, and it's been shown to also be on your skin. If you then get into a bathtub and sit there and have a nice soak, as good as that's going to feel, you're potentially sitting then in water that's got spores in it, instead of showering and having them all come off. Now, that's one thing we need to confirm, but it's kind of one of those things that it feels like it's common sense that we could think about as a way of reducing risk. Now, there's another thing that I haven't talked about in here, and I don't know if it's in the literature. I've never come across it in my whole 10 years of my PhD and my career before that, but thinking about sexual practices too, because depending on what people do, fecal oral could be involved, and that is a really great way for transmission to happen. So I think our guideline's going to need to address that as well. Also, avoid sharing personal items like towels or clothing if possible. And of course, you're probably thinking, well, I can't put bleach on my couch, which I totally recognize that. So during that 5-week period, you may want to cover soft furnishings with something that can be laundered. Now, I know another question is about laundry. And so we need to investigate that too. Most advice says to use regular laundering processes. And the biggest risk is when you're handling the dirty laundry that may be contaminated with feces, right? When you put it into the washing machine, that will dilute things, and then the rinse and the spin and all that, it goes out the drain. And then you put it in the dryer, which the heat may have some impact. But remember, I said that the spores are resistant to heat. I don't think the temperatures are necessarily hot enough to kill the spores, but they will have been reduced by the washing part. So at this point, we don't have any other advice except if you could, you might want to consider adding bleach to your laundry because the bleach would help with that as well. So, if you might be interested in participating in the guideline development process, I would ask you to send me an email. And when I say participating, it might just mean answering some questions about issues you've had or things you've experienced. Or when we get the guideline and the product's finished, you could review them and give us feedback, whether you think they're good or not, or they're unclear, or we need to have other information. And now we're at the part where I'm going to stop sharing my screen. and we can talk about questions. Oops. There are some references there, and I'm sure you'll provide the slides if people wanted that, because I know they might not have got a chance to absorb it all as I went through.
You want me
Hey,
to read? Sorry.
that was, oh, sorry, I remember you were gonna say something?
I was going to ask if you want me to read off the questions
Oh,
that
sure.
we've got. Yeah.
Yeah, sure.
Okay. The first one is, how long do I need to continue to sanitize with bleach after completing antibiotic treatment and I'm symptom free?
So I think that would be that 5-week period that I mentioned. So evidence shows that 5 weeks following treatment, you are probably not excreting spores anymore. Now, the spores that you may have deposited before that could potentially be in your environment. So that's when you need to do a really good clean. I should have said too that anybody who's here who's had C. difficile, I'm sure that it's an extra effort and very difficult to think about doing the cleaning yourself. So if there is anyone who can help with that, that may be a better way to do it. And I think one of the questions that came up at the beginning was, uh, oh goodness, I totally had a brain fart there.
Somebody asked if they could have somebody in to clean.
Thank you. Yes. Yes. Oh, you first. It's been a long day. So yes, you could. Sorry, Aaron, I know I'm jumping to another question. You
Go for it.
can, and presumably, when we are able to help get education out to providers, they will know what they should do. And they may already know that, right? That they need to use sporicide and gloves and gowns and that sort of thing just to protect themselves. So people who are cleaning should have protocols that they can follow as well.
Next
And
one is an interesting topic. How do I clean the litter box and litter mat for a cat who previously tested positive for C. diff toxin A?
So great question. If it was previous, well, you know what? I don't know for sure that animals have that same excretion time. I know colonization can be transient though, meaning that once you have colonization in people and animals, it doesn't always stay with you. So for some reason, your normal flora just fights it off at some point. But I would say if you wanted to be sure, I would do the same thing. I would mix up that solution of bleach that's 1,000 parts per million. I would throw out all the litter that's there. I would soak that litter box, and you can soak that for 10 minutes, right? It's a nice container that you can do. And any litter mat or anything like that, I would soak that in the bleach solution as well.
Can you please share some recommendations for laundry, specifically for underwear that wasn't soiled but was worn while the patient was contagious with C. diff?
Yeah, so if it's not soil, that's good news because that if it is soil, there's going to be a lot more spores there. If it's not visibly soiled, there may be some spores. And it's not always a guarantee with every bowel movement or even that it's always on your skin. So that's good news there. So that means there may only be a low amount. But I would say just put it through the regular laundry. And if you could add some bleach, but regular laundry is really the best we can do at this point. The wash water will dilute it, and the drying will hopefully um, finish off any spores that might be there. But that is one thing we're going to investigate in our guidelines because I really want to feel confident that the temperatures of washing and drying will destroy the spores.
The next one is, I do not have an active infection but am colonized with C. diff. Can my partner or anyone visiting my home and or using the bathroom contract C. diff from me?
So you could excrete spores into the environment. Chances are it's fewer spores than if you have an active infection and you're having diarrhea multiple times a day. What would happen if somebody picked up, like touched a surface that was contaminated and then swallowed those spores? They may become colonized too. So it is possible. The risk is lower if you are not having symptoms, and the risk is even lower if you start to use the sort of protocols that I mentioned, where you can think about cleaning. It's up to you at this point if you're just colonized, whether you want to think about cleaning after every bowel movement or not. But that would be to me the safest thing to do. But you kind of have to think about your risks and the risks to other people in the home. If they're generally healthy, then that's different than if somebody is immunocompromised in some way. Well, then you're going to want to do more hygienic cleaning.
Okay. I think you probably covered this one, but how do I clean upholstered furniture?
Yeah, so there, and I see somebody talked about peroxide cleaners too. Accelerated hydrogen peroxide is a chemical that can be used and often is used in healthcare settings on soft furnishings. So if you have access to that, and depending on where people live, that may be something that they do have access to. Uh, what you need to do though is check. So Patricia, you said you bought one that said it kills C. diff. I think it's list K from the EPA in the States for you that lists all the cleaners that are sporicidal. It's specifically for C. difficile. So check that because sometimes the concentration of the hydrogen peroxide is not sufficient to kill C. diff. So just like anything, you may need to check that it's sporicidal.
I think the
So
standard 3% one that you can find at like Walgreens and First Aid is not effective, but if you can order the special 6% strength one, that should be.
yes, exactly. If you can order that, that's great. And make sure you pay attention to the contact time for that too. So that may be something you can put on your couch, but sometimes you can't clean your couch without potentially ruining the surface of it, right? So that's where I was suggesting at this point, the best advice I could give would be to put a cover on it until, and only the person with C. diff sit there until you can clean that and feel confident that your 5 weeks after treatment period has passed.
Next would be, how likely are you to reinfect yourself with surviving spores in your house after treatment ends if you wash your hands constantly, take care not to touch your surface, and disinfect as much as you can?
All those things are great things and they will reduce the risk. I can't give you a specific number. We do need to do more studies and maybe that could give us some numbers. But anytime you do any of those things listed, that will reduce the risk. Now, I don't want to give the impression that like washing your hands constantly, like obsessively to the point where you're drying your skin out, that's also not great. But washing your hands after bowel movements or touching things that are fecally contaminated or potentially fecally contaminated and before you eat, that's great. Like you don't need to think, I haven't washed my hands in 20 minutes. I should go do that if all you've been doing is sitting at your computer or looking at your phone or watching TV. You have to think about, did I just maybe contaminate my hands? I should wash them. Or I'm going to eat or put my hands in my mouth or in my baby's mouth or something. I should go wash my hands first.
Um, the concern is with the transmission from violent automatic flushers in public bathrooms. What can I do to safeguard myself?
Yes, my concern is that too. Now, not necessarily C. diff, but there could be all kinds of other things in there too. And I don't know about where you're located, but here, like at the college and other public bathrooms, they don't have a lid. Because if they had a lid and I could close the lid and then flush it, I would feel better. So what I do is I hold my breath and try to get out of there as soon as possible. That's not great advice, but I don't know what else we can do in public bathrooms.
How can I keep C. diff from reactivating? I'm guessing maybe on surfaces.
So on surfaces, when it's outside the body, it's going to be a spore. So it just survives there until, I guess, we don't know at what period, like it stops being a viable spore. But for sure, 5 months is what I have seen. And people I worked with said it's a lot longer than that, probably. So the spores, they don't necessarily reactivate, but they stay active on the surfaces. But if you mean how can you stop like the recurrence or reactivation of C. diff because you're getting it multiple times, um, then as I said, that could be from a treatment failure. And then there are other treatment options, which I'm not an expert in and won't really speak to, but you should talk to an expert who could help you there. But if it is about recurrence in the sense that you might be reinfecting yourself, all these things that I've talked about could be helpful. So disinfecting with an appropriate sporicide for the right amount of time at the time when you've contaminated things, and making sure you clean your hands after you touch contaminated surfaces and before eating. Those will all reduce the risk of reinfection.
Um, Healthcare workers push laptops room to room and use them / type while giving oral medications, seen for speech pathologists and radiologists feeding patients during testing. What are your recommendations for hand washing, gloves, and I guess sanitization?
Yeah, that's great. I mean, that's the biggest risk, right, with healthcare providers in these sort of settings. So, um, in Canada, and we took it from the World Health Organization, so maybe many of your healthcare settings have it too. We have a hand hygiene program that educates people on that. So just like I've said to you, you need to think about the places in your home that might be contaminated and the times you need to clean and the times you need to clean your hands. We do the same kind of education with healthcare providers. So if they are typing or touching the cart and that's potentially contaminated, they need to clean their hands before they dispense medication and give to another person. So we call those the moments, or really the critical control points, when they need to clean their hands. Now, gloves, I think, can be good if used appropriately, but sometimes people put on a pair of gloves and they wear them all day and they think that they're protected. But gloves can pick up things just like our fingertips do. So gloves need to be changed a lot if you're going to use them in healthcare. And so sometimes I think hand washing is better if the people are well trained and they know when to clean their hands. It's definitely a tricky thing and one of the most common ways infections transmit in healthcare settings.
Okay, next one. We covered peroxide cleaners. Okay, and we covered public bathrooms. So then the last one is what about UV? UV
Being
sanitation. Yeah.
Yes, so there is some evidence that that can be effective. I don't know about people using it in the household though. If you have access to that and you know that the concentration of the light beam would be enough, then that's good. But the thing, and the reason they're not widely used in Ontario, Canada anyway, is that you might put that UV machine in the middle of your room, but if there's anything in the way that creates a shadow, that UV light can't kill those spores. So it's a little tricky to use them. If you have a machine and you know how to use it, though, it's probably as effective in a household as it would be in a healthcare setting. I just don't know anybody who has used it, but it is something that can kill the spores.
That covered everything we have. Some of the questions asked weren't quite on this topic of like household hygiene or cleaning. And for those, we're happy to follow up with people outside the webinar. So yeah, I tried to get everybody in the chat, I think. Someone
Okay.
else said hydrochloric acid is sporicidal. I don't know how safe that would be to handle.
Yes, I have seen in Canada we have a separate list to your list K, and that is on there. But I don't think they're products that are readily available for the public because of the safety concern.
Yeah. Is there a home surface test available?
Interesting. So I just at a conference I was at the other day, Diversey, which is a company you may be familiar with, they have this process. I don't yet understand it, but it's called Live, Liv, and you can use these goggles and this flashlight, and it will show you spores that are there. So
Is
there is
it
something that
They're a
exists.
fairly new company, like we've just started talking with them recently, but they are working on developing an at-home patient kit for that patients could purchase and use at home. So I
Nice.
don't think there's necessarily a patient, like a home version readily available of that product yet, but it is
It's coming. Which
coming
would
at
be
some
great,
point.
right? Because then you don't have to guess and think, could that be contaminated? You put on your thing and you use your flashlight and oh, there's some contamination. I will clean it. Yeah, that will be a godsend. That'll be amazing.
Yeah, and my understanding, because I was talking to them, emailing with them the other day, is they think it'll be available, the home version for household will be available around the new year, so like around the holidays or soon into the new year. So
That's great.
that'd be good. Yes, we will share the presentation and slides and the recording. Erin's beating me to answering some of these
I
things.
know, I think I got them all. I am trying to scroll through and see if we missed anything.
I feel like we got.
Will that home kit be FSA eligible? That's a great question.
I'm sorry, I didn't catch what you said. Oh, the
She asked if
Flex
the home
spending
kit would
account?
be, yeah, flex spending account available. So
oh,
that would be a great question that we don't have an answer for.
right.
So it's,
I think I think you'll have to see whether it's considered like a medical device or like
Mm.
where you're purchasing it from. But yeah, I mean, it depends. Some FSAs are really fast and loose, and other ones are kind of more strict. So it probably will depend on your FSA, but I think it's worth asking.
Yeah.
Actually, we did get a question in here. Somebody asked that chlorine bleach can be dangerous to cats, so I assume that if you clean, did we answer that already?
I just was answering it now, so thank you for asking that. I love cats and I wouldn't want to have your litter. So totally after you've had the 10-minute soak, then get rid of that bleach water and then you can rinse it out. And rinse the mat too after you've soaked it.
I think we got everything, and
Good,
and I think
right
we're
on
finishing on
time.
time. Good job, everybody.
Whoa. Right.
um, this was really uh this was really great, Kathy. Erin, thank you so much for being our queen of questions tonight. Um, as I think was mentioned in the chat, we will be sharing the recording. We might have to edit a little bit just to make sure that it doesn't it's not us sitting here waiting for the people to join in the beginning. Probably cut that off.
Yeah.
And the slides as well. So probably in the next day or two. And thank you for everyone who joined us, who asked questions. We're excited to be working with Kathy. Definitely if you want to participate. Maybe Kathy, want to drop your email into the chat one more time.
Sure.
You can reach out to her. Erin also put in the list how you can reach out to us. So if for some reason later you don't remember Kathy's email or you've lost it, you can always reach out to us and we'll put you in touch. Because we're looking forward to working with Kathy as we keep going.